Well, good afternoon, everyone, and welcome to this forum. We're here to discuss questions around the COVID-19 pandemic. I'm Dr. Heidi Manning, and I serve Misericordia as the Dean of the College of Arts and Sciences, and it's my pleasure to organize and to host this event. As everyone is likely aware, this virus is something new that we have not seen before. Scientists are working hard to understand how the virus works and to develop tests and a vaccine for it. This pandemic, created by this virus, has broad-reaching effects. It is impacting so many aspects of our society. And so this forum is created to help answer your questions, not only about the biology of the virus, but also about the many different areas impacted by COVID-19. We've assembled a panel of faculty from Misericordia University who have expertise in a wide variety of areas. I'd like to begin by introducing the panelists. Dr. Frank DePino. He's a professor of biology and also serves as the chair of the biology department. Frank is a molecular biologist whose research interests are in protein and DNA interactions and the proteins involved in cancer cell regulation. Dr. DePino regularly teaches microbiology and molecular and cellular biology courses at Misericordia. Erin Burns Kilduff. She is the program director of Misericordia's Physician Assistance Program and has been with Misericordia since 2017. She's been a physician assistant for 17 years and has worked in various specialties, including surgery and integrative medicine. Dr. Annette Weiss is an associate professor of nursing and serves as the assistant dean of nursing and the chief nurse administrator at Misericordia University. She's been on the faculty since 2000. Dr. Weiss's interests include population health and the impact of COVID on hospitals, workers, nurses, and making sense of all the statistics gathered through this pandemic. Dr. Amanda Caleb. She's been on the faculty at Misericordia for 10 years and is an associate professor of English and Medical and Health Humanities and the director of the Medical and Health Humanities program. She is interested in the intersection of public health and the humanities and is currently writing the foreword to a forthcoming book on pandemic rhetoric. The foreword being written focuses on the delay and the impact of using the term pandemic to describe COVID-19. Dr. Samantha Banerjee is the assistant professor of business. He joined Misericordia University in the fall of 2015, and his research interest is in the field of applied microeconomics. As you can tell, we have assembled an excellent panel with a breadth of expertise to answer your questions. Many of you submitted questions in advance, and I thank you for that. We'll begin with those questions. And some of them are related, so we may be combining a couple of them that may be similar into one question. If, during the course of this discussion, something comes to your mind, feel free to write your questions in the Q&A box that is at the bottom of the screen. We'll try to get to as many of those questions as time permits. But let's get to the questions. I'll start with one for Dr. DePino. Can you explain how this virus is similar to other viruses and how it's different from other viruses?
Sure, I think it's important to note what viruses are to begin with. There is a debate whether viruses should be considered alive or not. I don't want to get into that big a debate, and I'm not even sure it's important in this particular situation, but what is important is that people understand what a virus is, and it's an infectious particle. So it's something that outside of a cell, if it's not in our body and in our cells, if it's not in a host cell of some sort, then it's completely inactive. Viruses outside of cells do nothing. They can't come looking for us, they can't fly, they can't swim. The only way viruses can contact us is if we move into them or somebody moves or something moves them into us. So I think it's really important as we talk about social distancing and the other major aspects of this pandemic, to keep that in mind, viruses are not as scary when we think about them outside of our cells. So another important fact is they're not cells. So they don't have the complexity of cells. Most viruses are simply protein and DNA or RNA. Protein, DNA, or RNA, not usually both like cells have. So they're kind of odd. Some viruses have good old-fashioned, kind of what we're used to seeing in cells as their genes, DNA, and good old-fashioned, as we're used to seeing it, double-stranded DNA. And then some viruses have odd DNA, something we didn't think existed before we found it in viruses, single-stranded DNA. And that's the form of their genes. So that's really odd. Viruses are always bizarre, always doing odd things. In addition, like the current virus and many of the ones that infect humans, there are RNA viruses. So these viruses don't have DNA as their genetic material at all. They have RNA. And some of them have RNA, kind of like we're used to seeing RNA, single-stranded, sometimes one strand that we call a plus strand, which makes sense. That's what this virus has. Some viruses have something called a minus strand, which is the antisense. I'll talk a little bit later about those. But this is an RNA virus, so it's odd in that way too. These viruses are always host specific. So they infect one species, and then further than that, infect only one cell type. And I'm sure you're thinking, well, wait a minute now. This virus just went from pangolins or bats to pangolins to humans. How did that happen? Well, changes had to occur. We can talk about that. Maybe there'll be another question that comes up. But there isn't anything on Earth that isn't infected by viruses. And all they do is to get into our cells. They've evolved a very good way of doing that. And once they're inside of our cell, they pirate the cell. They take it over. They pirate the machinery of the cell for one purpose, and that is to reproduce themselves. And whatever kind of genetic material they have determines how they go about doing that. And this virus is extremely interesting to us as molecular biologists in the way that it does that, because it has this plus strand RNA genome, and it does some really weird things in producing its proteins. But all of these viruses are going to be doing that, reproducing, and then when they leave the cell, they tend to scuttle the cell. The cell usually dies after some period of time. And so it's really important for us to understand the complete infection cycle for all of these viruses, certainly this one now, because that's how we develop the drugs and the antivirals. Those are the monkey wrenches that we can throw into those most vulnerable steps that the virus does once we understand them.
Thanks. Can you explain a little bit more about how the virus infects our cells and how that leads to COVID-19?
Yes. So as I said, maybe the first thing we should talk about is how does it get to us? So these viruses, there's 219 viruses known to infect humans right now. There's about 3 or 4 more added to that every year. And 2/3 of them come from animals. They're zoonotic. So they are in animal populations, and we call that the reservoir for the virus. That's where the virus persists. They need to go through some kind of change because, as I said, they're usually species, and then further than that, cell-specific. So they go through a mutation change, which allows them to now recognize cells of another species. And very often, that's a one-time event. Very often, that's one animal infecting one person. That person gets the disease, and that's it. Another person to get the disease would have to be infected by another animal. However, what often happens, unfortunately, is these viruses then go through a second change, a second mutation, which allows them to go from one human host to another human host. That's when the virus becomes more dangerous. And eventually, and unfortunately, what's probably going to happen with SARS-CoV-2 is these viruses become constant in the human population. They become endemic. So that's probably where we're heading for this particular virus. With that all said, the reservoir, therefore, is thought to be bats for most of these. There's 7 coronaviruses in total, 3 more recent ones that are more deadly than the common cold type viruses that we used to be able to control and just deal with every year. So these more serious ones, one in 2003 was the SARS-CoV-1, One in 2012 was MERS, the Middle Eastern Respiratory Syndrome virus, all coronaviruses, and now the SARS-CoV-2 virus. All of these viruses share certain characteristics, but they are different in some ways. SARS-CoV-1 and SARS-CoV-2 both bind to epithelial cells in the lung by way of a receptor called the ACE2 receptor. It's the angiotensin converting enzyme 2. This is an enzyme that normally functions in the membrane to cause the decrease of blood pressure. But what often happens with these viruses is they tap into the cell's normal circuitry to get in. So these viruses have evolved a spike protein. Virologists call this a spike protein. Most of us in cell biology would just call it a membrane protein. It's a protein that emanates out of the membrane of the virus. So because it sticks out of the membrane, it looks like a spike at the electron micrograph. And then with these viruses, because that spike is so prominent, it gives the virus, which is spherical, a kind of crown-like appearance. So that's why they're called coronaviruses. It uses that protein to attach to the surface of our epithelial cells, lining the respiratory tract at some point, either in the upper parts or unfortunately sometimes deeper into the respiratory tract in our alveoli cells, or alveoli where the epithelial cells are. And that attachment then allows the virus to recognize, this is my host, this is where I'm going. The next step is there's unfortunately a host protein that participates in this process. It's a protease that cuts the angiotensin converting enzyme receptor. That stimulates the virus to, we're not sure, there's two mechanisms possible. The virus's membrane fuses with the membrane of the cell. This is how some viruses like HIV gets in. But then other viruses also are endocytosed. And we think that this virus is one of those, approaches the cell one of those two ways. Once it's inside, the RNA is encoded, and what's really strange here is because this is a plus or sense RNA, the cell directly translates. Unfortunately, the cell's tricked into translating the virus's plus RNA, which behaves like, if you remember some biology, behaves like an mRNA, a messenger RNA. That directly produces one of the major proteins of the virus called a replicase. And that replicase then causes the RNA to go through another weird step. It's got this plus RNA, it makes minus RNAs using that strand as a template, makes plus strands, more plus strands, a whole bunch of nested RNAs, mRNAs that encode the rest of the proteins. Try to make a long story short here, those proteins then assemble and the virus leaves by an exocytosis process, a kind of budding process from the cell. That's the entire cycle, and unfortunately, as the virus leaves, it damages the cell. And unfortunately, as it leaves, it very often go deeper into the lungs and do further damage and cause severe pneumonias.
A quick follow-up, a question that's come up from the audience. How long does it take for the virus to reach the lungs once it's entered the body? And is there any known way to prevent the virus from reaching the lungs and therefore the potential to cause most deaths?
That's a great question. Maybe some of the folks from health sciences want to chime in too. I'll take a quick shot here, but I think that we have good evidence to suggest that this variation we see in the seriousness of the disease might very well be due to what this person's asking about. How does the virus, how deep does the virus go into the respiratory tract? If it's in the nasal passages, if it's in the upper parts of the respiratory tract, perhaps the person fares much better. And when it goes deeper into the respiratory tract, the production of this ARD syndrome occurs, and that's when I think patients really get into trouble. Certainly those kinds of things that might slow the virus from being able to enter the respiratory tract, social distancing, masks, those kinds of things are going to assist in that process. There are drugs for some viruses that prevent the virus from budding successfully, from leaving the cell. And Tamiflu, for example, is one of these. It's a neuraminidase inhibitor that prevents the flu virus from leaving the cell very easily. So that was thought, it's in theory anyway, we're not sure if it really works. It's thought to prevent the virus, the flu virus, from going deeper into the lungs. I don't think that we have any antivirals right now that, and the neuraminidase inhibitors are unlikely to work for COVID-19. But that's a little bit beyond my expertise. I don't know if somebody from health sciences want to chime in on there.
I think I would just add that it does seem to have a progression. So where patients, again, we're still looking at the data, we don't have all of the data, but early studies are kind of showing that there can be a rapid progression after patients have had it for 7 to 10 days, and then there's a rapid decline where patients are developing the ARDS, so where it gets into the lungs in a more severe way.
I think the other thing that we're seeing is that people are confused or they don't know when to seek help. And the issue is they have confounding medical problems, all kind of things. Age definitely is not on your side. So we're seeing a lot of the deaths in the older population, but it rapidly progresses, like you've said, into a full-blown respiratory situation where they need a ventilator. And more substantial support almost immediately. So it's important for people to know, if you're sick, call your doctor. You don't have to drive there. But if you're really sick, you need to know you need to get to that emergency room. And I think that's where, you know, it's a fine line. They don't want you to go out. And at the same time, they really, you know, they want you to come out if you're really ill. So.
Very good. Well, thanks so much for sharing a bit about how the virus infects us. We've got a couple questions about how we can care for ourselves and others. Erin, I'm wondering if you could speak to this question. When should I go and seek medical care for symptoms, and how should I do it if I think I may have symptoms related to COVID-19?
That's a good question. Symptoms related to COVID-19 can be respiratory, as we've talked about, some coughing. You may see flu-like symptoms such as fever, chills. We've even seen some new information that suggests nausea, vomiting, and diarrhea are possible symptoms as well. Sore throat. If you have symptoms that might indicate that you have COVID-19, the first thing you should really do is call your medical provider. Your medical provider is going to give you guidance. What should you do and where should you go? As Dr. Weiss just mentioned, you know, we don't necessarily want everyone driving to the emergency room or going to your clinic, because if you're ill, that means then you have the potential to pass on these symptoms to people in the community. So we want to make sure that we're doing this in a safe, healthy way. And your medical provider is then going to guide you. Do you need to go to a testing site, and which testing site should you go to? There's also the chance maybe you don't have a medical provider, and you can call the Department of Health, and the Department of Health will also guide you and let you know if you should go to a testing center and which site to go to as well. It's important to note that in emergency circumstances where you might have more severe symptoms, such as severe shortness of breath or difficulty breathing, chest pain, maybe you're having some loss of cognitive, where maybe you're confused. In these situations, you really do want to call 911 or get yourself to the emergency room. But for those milder symptoms, you're going to want to call and seek the guidance of your medical provider first.
Yeah.
The statistics seem to say that about 85% of all patients at this point can just self-treat at home. So just like you would do for having a normal fever, if you have a fever, you need to drink lots of fluids and you need to rest. They're suggesting that you try to isolate away from the people in your house. It's easier said than done a lot of times, but certainly common sense, anytime you're sick, you don't want to go to the grocery store if you're ill. You don't want to go in if you have a fever. Hand washing, all those things that are important to do, we need to do every day, not just now. But it's just really important to first call, like Dr. Kilduff said. It's just usually, and I've used it myself recently, not for COVID symptoms, but they're doing a lot of telehealth right now. So my daughter's doctor got on a conference call with us just like this and was able to look at her and speak to her and provide her guidance without us having to drive to the office. So it's another option available for patients too.
Mm-hmm. We see a lot of images from New York City and some of those places very hard hit by the COVID-19, and we see what's happening in the hospitals in that situation. I'm wondering, Dr. Weiss, if you might be able to speak to what we're seeing in the hospitals around Scranton and Wilkes-Barre right now. Are they overwhelmed? Are there enough ventilators? What's the situation like?
Sure. I think in the beginning, everyone was just hyper alert and hyper vigilant, and we were ready. I think what we're seeing now is that it's getting steady. It's not overwhelmed in this area. We're very, very lucky. On a normal day, I read out of New York City, you know, people are in the hallways in the emergency rooms. On a normal day, any time of the year, you go into the hospitals and the emergency rooms, and when they're overcrowded, they're overcrowded. So I don't think we're finding locally anybody that's overwhelmed. A friend of mine is in the Hazleton area, and she thinks that they have peaked in the Hazleton area and they are seeing less patients. On the Department of Health website right now, you can look at all the statistics every day. They update it frequently, and it seems like at least 50% of the hospital beds are still open. There are plenty of ventilators, at least 50% of them just in the local area. And you can look at the state data too and see around the state how it is. The western side of the state is doing much better than we are. The Pittsburgh area is actually in pretty good shape. The Philadelphia area is not as fortunate. So I think we're kind of in between the two areas. I think the hospitals, a lot of the units were converted to COVID units. The good news and the bad news is there are nurses who aren't working because they are doing elective procedures, and they've canceled those, and rightfully so. So the good news is we're not overwhelmed right now, and social distancing, you know, taking good care of yourself, good hand washing is helping really flatten the curve.
Erin, do you have anything more to add from your perspective on as a provider?
I would agree with that with Dr. Weiss, and also just adding that the measures that we're taking have certainly helped. As we said, we don't want patients just coming to the emergency room for minor issues that can be resolved maybe through telehealth or over the phone, and that has seemed to help. I have quite a few friends and colleagues that work in the emergency departments locally, and they have said they've seen their census drop in the recent weeks. So we are seeing that social distancing and getting the word out that patients should call their healthcare provider before coming to the emergency room has been helping as well.
Very nice, thank you. Thinking a bit more broadly about how we care for people, we had an interesting question posed by a student that I'm going to ask Dr. Caleb to address. Why is somebody from the humanities on this panel, and what role does the humanities play in something like COVID-19?
I feel like I sometimes am the odd duck out in some of these panels. So, you know, I think there's some obvious ways we can think about the role of the humanities right now that some of us are experiencing, you know, day-to-day benefits. The expansion of book clubs via Zoom. Those of you who've been looking at art online, if you've been following any of these wonderful Twitter accounts from museums and the archivists who are posting, you know, these wonderful competitions about who has the creepiest artifact. That started with the Yorkshire Museum. If you've been watching any of the theater that's been on Broadway, the National Theater in England has been putting on productions for free, having them on YouTube for periods of time. So, you know, that's something I think is really important, and it reminds us that we're not alone. Because, you know, social distancing, shelter in place can be incredibly isolating, particularly even if you're in a home with a lot of people, it can feel very isolating. And it, you know, it reminds us of our own humanity, right? That we get to kind of have this sort of escapism, if you will, but it reminds us kind of what we value as a society. More broadly, of course, you know, the ethical discussions that are going on come out of, you know, the humanist tradition, the discussions of ethical and just treatment when it comes to, say, allocation of health resources, testing, allocation of, you know, ventilators in more hard-hit areas, et cetera. The thing to remember about the humanities is kind of what we represent, what we study. When we talk about the humanities, we're thinking philosophy, languages, literature, history, art history. These are all part of this broader category, religious studies as well. And so what they all have in common is they study ethics, they study representation, and communication and how they function in a society. They study cultural assumptions. They study images and words in communities and how that relates interpersonally. And so when we think about all of what's going on there, the role of the humanities, I think, can be pretty substantial when we're talking about pandemics. And we've seen bits and pieces. You've seen historians, I think, a lot, particularly, when we were first talking about COVID-19 in this country, the comparisons to the flu in 1918, 1919, and that's coming from a lot of historians who are saying, let's look at what social distancing looked like then. Let's look at trends. Let's look at the difference between Philadelphia and Kansas City and other areas. You have disability scholars and activists who are actively involved in some of these major decisions about triage policies and allocation of health resources in hospitals. And that's a big role to play because we have to think about people with disabilities, with physical limitations. There's a lot of obstacles to actually getting tested and getting treatment, in addition to obstacles for people who have a language barrier, let's say. So a lot of those structural obstacles humanists are trying to draw attention to. I think it's interesting in Germany, they recently created a committee on how to kind of re-enter society, so to speak, their plans as they move out of more widespread shelter in place. And on that committee, they have philosophers, they have historians, they have theologians. Now, this is part of a very rich tradition in Germany where humanists have always played a major role. But I think that's something we should be thinking about more broadly everywhere, because you have these perspectives that are going to think about the ethical implications, but also the broader structural issues that we are living with in countries. And I think, pandemics really draw attention to the limitations of a nation, right? We see where healthcare can be at its brink of not working, right? It's stretched to its absolute limits. And so we have to think structurally, it's not just the people working in healthcare, but outside, where are some of those issues coming from? Where are some of the issues of access to care coming from in terms of different groups? So I think the humanists, you've seen some, in your day-to-day, if you've been watching theater, but think more broadly about how, this can help shape how we come out of COVID-19 and how we respond as a society in terms of what we value, but how we can kind of critique some of the systems we have in place already.
Thank you. Moving more to the broader impacts and thinking about the economy for a little bit. Dr. Banerjee, there's a question. Are we in a recession right now?
Thank you, Dr. Manning. That's a very good question. Now, in one sentence, nobody can officially say if we are in recession or we are not. Let me explain. Now, in order to declare recession, a country's income, in economic term, we call it gross domestic product or GDP. It must be falling for 2 consecutive quarters. Now, we just completed our first quarter in March, and we are in our second quarter. So we do not have enough data to call it a recession right now. Second thing is, when it comes to this kind of data, they are not real-time data. It's not like something is happening right now and we are updating our database. It takes months, even years, okay? However, what I can predict is that at some point in time, this time in near future shall be called a recession. There is no doubt about that. And right now, if you're looking at countrywide unemployment, it's nearing 5% on average. And there is no doubt we can easily predict it's gonna cross 10%. So at some point in time in near future, we are definitely gonna call it a recession because we are still going downward. The economy is still going downward and it's gonna go downward further. Now, NBER, our National Bureau of Economic Research, they are located in Boston, Massachusetts. They have the authority to call an economic downturn a recession or not in this country. They have not declared yet that we are in recession, but I predict they're gonna do that in near future.
How does this current situation compare to the Great Recession and the Great Depression that this country's experienced?
Okay. Let me, now, the economist, and his name is Gregory Mankiw, he just coined a term for this this current economic downturn, and he called it designed recession. But if we compare this with our previous Great Recession, he would call it accidental recession. Now, in layman's term, how we know if it's accidental or by design. Now, if you think that a human body is an economy, and that body is sick, that body cannot eat, and that's why that body does not demand food, we will call it recession by accident. However, if that body's two hands are tied by somebody or by something, and that's why that body cannot feed itself because those hands cannot come up to the mouth, then we will call that kind of recession as recession by design. And of course, if those hands are tied for enough long period of time, it's gonna be a regular recession. Now, let me compare this to our 1930s Great Depression, okay? Notice there is a difference between those two. One we are calling recession, another we are calling depression. So, jokingly, an economist said that a recession means when your neighbor loses job, and a depression means when you lose job. So, by saying that economist wanted to say that a depression is more severe or more intense than a recession. We would call an economists, we would call an economic downturn depression when it's gonna be longer lasting and it's gonna touch 27% of unemployment rate at some point in time. Okay, but and that's the difference between recession and depression. If you remember, the 1930s depression, it lasted over 10 years. The actual recession, forget about the mental or psychological impact it had. But in case of recession, if you look at our Great Recession of 2008, it lasted just for over 2 years. And with this COVID-19 recession, that we cannot call it recession, the economic downturn, so we are ending the longest lasting upward economic trend in the entire US history. Okay, and so yes, it's when it comes to pain, psychological pain, loss of jobs, social strain, this kind of fact, it is not gonna be as severe, I predict, it's not gonna be as severe or intense as our Great Depression, but it may well be in that ballpark.
Thinking about the economy and the impact of this, there's an interesting question that was posed to the panel. If you look forward, what new jobs or career opportunities do you anticipate in the post-COVID-19 world? And I invite all of the panelists to respond to this from your perspective in your different disciplines.
Thank you. That's a great question. And I would say definitely when we come into our new normal, then we are going to experience shift in resources across the industries, okay? Now, what I mean by resources? By resources, I can say starting from environmental resources to human resources, okay? So what I predict is that the online stuff. So it's online stuff means I'm talking about software industries. I am talking about online shopping, these things. Then I'm talking about, let's say, Netflix. Okay, there is difference between watching Netflix and going into movie theaters. Of course, what I expect is that right now we are still shaky to do some stuff online. However, when we are forced by this current situation to do our jobs online, then some people may get accustomed of doing this, and when they get fun of doing that kind of stuff, they may just stick to, even after the recession, the virus situation is over, they may still stick to their online behavior. They may not return to what they used to do before the virus situation. So I would say that it is not that every industry is going to be impacted equally. Every industry is not, when it comes to intensity, not every industry is going to be like equally, what should I say? Not every industry is going to experience the negative stuff, and every industry positive, but there will definitely shift in that kind of thing. And I was just listening to Dr. Kilduff and Dr. Weiss, and they were saying that you first consult with your doctor. It could be online or over the phone. So when we look at medical industry as well, so probably in that situation, after the virus situation is over, probably people will stick to that, and before they go physically or in person to the doctor, probably they're gonna first take their advice over the phone or online from their doctor. Yeah, so I'll stop here.
I would agree. I see that telemedicine will probably be utilized in a larger fashion in the healthcare industry. However, there is also the thought that it's driven really by what insurance companies will allow. So that's another layer. Will insurance companies go back to saying, no, you must be in person and there won't be as much telehealth, or will they, you know, open up their doors and allow more telehealth visits? So I think there's a lot of unknowns that we aren't clear about yet, but there is more opportunity for it as we've seen how it's working well for different people right now.
I think it's going to drive people either toward or push people away from healthcare careers. There certainly will be people who have been on the front lines. Certainly nurses in New York City are tired. They may seek other employment, they may stay, they may need some time off. And then there are a bunch of students who currently can't wait to get into the workforce and help. So I think it's going to push and pull both ways in terms of nursing, and I think many healthcare providers will either be like, this is great. There's certainly always jobs, so that's another good thing about the healthcare arena, and we certainly see there are many positions for people coming out of school, but there definitely will be people who stuck around because of the last recession and didn't retire that may be considering that now too. So nursing being depleted in and of itself on a normal day, we certainly need more nurses into the field, and this may both pull them and push them away.
I think another area you're going to see some growth is public health and public health adjacent areas, certainly in policy level, but also in fields like epidemiology, which is also, it's already been on the rise, biostats, any of those fields, but also I would imagine areas of health advocacy as well, because one of the things we're seeing in some of the data that's coming out is the inequalities that are happening in certain areas. So I think you're going to see a rise in some more health advocacy areas as well.
There was just a recent article from the American Society for Microbiology about this, and they talked about students having their education upended. But in terms of the sciences and the basic sciences, this is a fantastic opportunity because it's highly likely that we're going to see a lot more funding finally to really prepare better for these emerging infectious diseases than we have in the past. As I mentioned earlier, SARS-CoV-1, the early version of this coronavirus that was unique to coronaviruses and causing more deaths, caused about 800 deaths in 2003. Very little was done. We still don't have antivirals. If we did, they'd probably work on this SARS-CoV as well. We don't have dependable vaccines. We don't have the kind of work done in that long period of time from 2003 to 2019 that we should have. And now I think it's being recognized. So there's going to be a lot more federal money for basic research, studying vaccines, studying antivirals, and also a whole area of just being able to do the epidemiology in terms of the practical side of it. Trackers. We need people to be able to track infected individuals. This is how South Korea did so well with the disease. They were very aggressive in the way they tracked their infected individuals. It's been argued that maybe the U.S. society and our love for freedom might not allow that kind of level of tracking, and that very well may be, and maybe that's the way it should be. But I think as we prepare for the next pandemic, we're going to have a lot more attention given to vaccines, antivirals, tracking. We're going to need new virus hunters, these people that go out looking for the next virus in bat populations in other parts of the world. So it's in some ways going to be a great opportunity in the next few years for people in basic sciences.
Right. Lots of good careers await for students. We've had several questions about the term herd immunity. Dr. DePino, I'm wondering if you can describe what herd immunity is. Does it apply to this situation? And how likely do you think there will be a herd immunity in the population?
Herd immunity is actually a pretty complicated topic. It's due to a number of variables about the particular infectious disease that we're trying to gain immunity to. But what it comes down to mainly is just how contagious that disease is. The more contagious the disease is, the harder it is to achieve herd immunity. What herd immunity is sort of as the name implies, it's a level of immunity either achieved naturally by infections or by way of a vaccine that prevents the spread of the disease. You don't necessarily have to have the entire population vaccinated or immune to the disease in order to achieve herd immunity. What we have to have is a large enough fraction of the population either immune through a vaccine or through natural exposure to the virus and the buildup of antibodies and memory cells to that virus, so that if they ever are exposed to it again, the virus doesn't move further through that person. Each virus has what's called an R0 value. It's a term, but it really just comes down to something quite simple, and that is each infectious agent, such as a virus, has a certain number of people that it can infect from one infected host. So for example, measles or mumps, chickenpox, those are highly contagious diseases. So the R0 value, one person with the mumps or chickenpox can infect over 10 people. Luckily for us, with COVID-19, one infected person usually is thought to infect 2 to 3 people. That number is a little bit rangy, but that's about where it is. The trouble with this particular virus is it has a very long incubation time. So during that time, the person might be able to infect more people. So that's part of what determines herd immunity. And so what we think, best estimates that I've read for understanding the limited amount that we have right now for SARS-CoV-2 is that we would need about 70 to 80% of the population to be either naturally immune, or if we were able to develop a vaccine quickly, for the vaccine to cause that part of the population to become immune, so that the virus would be kept in check. What it basically does is knock down that ability for the virus to spread to its normal value of R0, because there aren't available hosts for the virus to spread to. we block enough avenues, again, we don't have to block them all, we have to block a certain percentage of the avenues for spread to maintain herd immunity. So the question comes down to another question that I heard asked about, is reinfection possible? Are we building up immunity? Most evidence suggests we are and will, but I think one of the major take-home points we should consider right now is we don't have all the information. And I know that's not very satisfying. It'd be much more satisfying to have concrete answers. But at this time, if people are giving concrete answers for most of this, they're likely inaccurate. They're likely exaggerated. So once we have that information about the number of people that are currently infected, we'll have a better idea of how contagious this disease is, and we'll have a better idea of what percentage of the population needs to become immune to it. The first SARS-CoV, people developed antibodies and memory cells to that. The antibodies lasted for at least 2 years. When they checked these individuals 5 years out, they didn't have antibodies anymore. However, they did have memory cells, which can very quickly turn back into the type of cells that produce these virus and bacterial fighting molecules called antibodies. So there's going to likely, we don't know, but best guesses are that we will likely be able to develop immunity. Secondary infections haven't been shown yet. Some controversy was created because the current tests, for example, the RT-PCR test sometimes comes back as a false negative. So what's happening is some people are testing positive, they have the disease, they test negative, and then some later date they test positive. Well, it's very likely that negative test was a false negative, and they were positive all along. They were still shedding virus, and that's why they tested positive the second time. The middle time, the negative test was probably an error. Unfortunately, the tests are not error-free. We're getting false positives and false negatives. So yes, quick answer, I do believe, it's my best estimate based on what I've read and heard from other people looking at this, that we will get herd immunity eventually. That's what flattening the curve is all about. And as people have pointed out, flattening the curve, I don't want to get into a whole nother topic here, but flattening the curve does delay. It's going to delay herd immunity. The best case scenario is if we had a vaccine today, we could achieve herd immunity in probably 2 months. But without a vaccine and with flattening the curve, we're likely talking about a year or more.
Here's a question that was posed. Do you see this pandemic having any significant changes on how we deliver healthcare in the U.S. or on our healthcare delivery system? And related to that, do you think telehealth is going to help contain the healthcare costs?
That's a wide question.
Good luck.
That has a lot in it. I think in reference to will telehealth help to drive costs down, it might. I think that is insurance company dependent to some degree, because they really set reimbursements and they set premiums. So it will have to do with, I think, the frequency of use of telehealth. And I do think that the delivery of care will change in a sense where we may be able to use telehealth as a first line before going physically to an on-site center for healthcare. But I also see this as very region dependent, and also knowing the resources that different patients have. There's all level of resources. So patients that are in an elderly population might not have access to telemedicine sources. They might not have access to a computer or a smartphone where they would be able to access telehealth. And so we really need to be mindful of that when we're thinking about the delivery of healthcare. And I would also say, I might be biased, but I still think it's really important that as healthcare providers, we see patients and we put our hands on patients, and as we're taking care of them, I think that that's a really important role. So I do see this as, I see telehealth as a part of healthcare. I don't see it as all of healthcare. I just see it as one role.
I absolutely agree with that. There's certainly something to be said for being in the same room with a patient. We don't only ask questions, we see, we touch, we smell, and all of these things give us insight as to what's going on with our patients. So it's very important in some cases that the patient is with us. If you get on a telehealth call with your provider, what I found personally was it saved me time and money. I didn't sit in a waiting room. I sat in my house, and the provider was very prompt. But that was for a very different kind of appointment. So depending what our healthcare needs are, will depend how useful it is or not. I'm not sure that overall it's going to save costs for healthcare in terms of my time with the provider is still my time with the provider, whether they're in an office or whether they're at a computer, it's still our time with them. So I'm not sure it's going to drive it down that much, but it certainly will keep more well people out of offices where more sick people are and need to be. That's, you know, absolutely where they need to be. So
I think,
oh, I'm sorry. Go ahead, Amanda. Go ahead.
I was just going to say, I think the issue with telehealth is really interesting. We talk about accessibility because Aaron brought up a really good point about if you don't have an access to a computer. On the flip side is that if you have people with physical limitations and disabilities, you know, telehealth is a really viable way to receive a certain level of care. And I think I 100% agree, you know, the hands-on in the room. And I really love that you used all the senses in describing the examining room. And I think that's so true. But for people who have issues with transportation, physical limitations, cost, you know, to take time off of work, this could fit in better. You know, I think that's something that, you know, we're realizing throughout this entire pandemic is issues of accessibility for groups of people that this is exposing, that we're saying, oh, how difficult. And a lot of people are saying, this is how I've been living. And I think we need to think about those balancing acts of the accessibility factor.
Dr. Caleb, can you talk a little bit about how COVID-19 and the layers of discrimination are we're seeing surrounding this pandemic? Can you, there you go. Did you hear my question?
We might have lost her.
We maybe have lost her.
Maybe just repeat it again.
Okay, asking you if you could talk about COVID-19 and the layers of discrimination surrounding the pandemic.
Thank you. Sorry, something cut out briefly on my end. I appreciate that. You know, we've seen a lot of things in the news, and I think that's important to keep in mind. You know, when we talk about discrimination, there's sort of the obvious levels, and then there's the less so. So when we talk about you know, acts of violence towards Asians, Asian Americans, boycotting of restaurants, Chinese restaurants, I'm thinking of right now, you know, that's kind of this larger level. Maybe one level down, because you're seeing it only if you're kind of looking for it or if you're exposed to it directly, is we're also seeing, you know, different rates in terms of infection, depending on ethnicity, socioeconomic class. I mean, New York City is going to be an incredible study once we have more data coming out, because you're seeing, you know, pockets of New York that have hotbeds of COVID-19 outbreaks, high mortality rates, and we're seeing, you know, factors of low socioeconomic, education attainment is lower. Certainly the proportion in terms of race, the representation of the population versus how many people are being infected, and mortality rate is going to reveal a lot about some of these structural inequalities. But I think another layer that we need to start thinking about already, that again, maybe some people have been thinking about or seen and maybe they haven't, is discrimination against people who have tested positive for COVID-19. I think this is really important. You know, the kind of shunning away. I mean, it's allergy season. If you're in the grocery store and someone coughs because it's allergy, there's this sort of, you know, don't come near me. And I completely understand it. But at the same time, I think we have to be very careful that we want people to actually say that they've had COVID-19. This is going to be really great data collection, particularly if they had mild symptoms, they didn't, you know, have to be in the hospital, in the ICU. But if there's going to be some sort of backlash to, oh, you got COVID-19, how did you get COVID-19? There's that potential level of discrimination. I know I sit on some ethics boards at local hospital, and this has come up as a topic, actually, is to make sure that there's no kind of unintentional underlying bias towards people who have tested positive for COVID-19. So I think we need to think about all these different layers, not just the ones that are, you know, headlines in the newspaper, though those are incredibly important. And we've seen a lot of this, not just in this country, across the globe, you know, violence towards Asians, but we need to also think about these other factors as well. And so I think you're going to see a lot more conversation about these issues of discrimination, and to go back to a point earlier, also about access as well. So this unintentional discrimination in terms of who has access to testing, to care, et cetera. And some of the data is starting to reveal, you know, these inequalities. I think one example that comes to mind is, you know, individuals who are received care through a visiting health service, right? Though they cannot leave their home to get care, so they have someone coming into their home to give them care, visiting nurses. If those visiting nurses do not have appropriate PPE, that's a significant risk for those individuals. And so that's something we have to be thinking about as well, is that while the intention is to provide good care, to provide the ongoing care for someone who is in their home, is there potential to actually cause more harm as well. So these are all these bigger factors that are tied into the issues of discrimination and really potential injustice that is either happening currently or could happen after the fact.
Great. Dr. DePino, one question that I have here is, will this virus ever disappear on its own without a vaccine, like what happens with SARS in the past?
Yeah, unfortunately, that seems unlikely. At this point, there's so many people infected with the virus. As I mentioned, it's likely to go to that third step. I mentioned that these viruses very often enter the human population from animals. They had to undergo a change, some kind of genetic change, to make that switch to humans, recognizing our cells, recognizing that receptor, which is going to be a little bit different on our cells compared to maybe another mammalian cell. And then they have to undergo another change before they can be moved from one human host to another human host. And then they eventually become endemic in the population. They become established in the human population, like many viruses have already, such as HIV. And unfortunately, it's likely to occur with this particular virus. With a vaccine, over time, we could probably eliminate it, but that would take a vaccine. At the present time, without a vaccine, it's likely to become endemic. Something like Ebola, where it impacts a village and doesn't leave the village, then we can keep it contained, and then it disappears until another variant comes into the human population. But unfortunately, this virus is global now, and the next potential worry areas are South America and India, and I think that it's very just likely to stay in the human population.
I have one final request for Dr. Caleb. Many people have listened to your WVIA interview with Erica Funke, and I think they're stuck at home and they're looking for a reading list. Can you give any recommendations?
Wow, it kind of depends. Do you want to immerse yourself further into this, or do you want to escape away from it? You know, I think The Great Influenza by John Barry, which is a historical account of the 1918 flu, is just eye-opening to see parallels to what we're going on now. Again, if you've been reading in the newspaper, you've seen people draw some of these connections, but he really goes into wonderful detail of the time period and the sort of absence of you know, journals and documentation. A lot of people were kind of embarrassed by their behavior, and so either they destroyed their journals and letters or they didn't keep them. And that's something, you know, we might think about parallels today. Hopefully we're not destroying these things. This is really important record keeping for historians, for us to understand what happened at a time. You know, the two I just taught in a class that I teach every year, and this year took on new meaning since we were remote and living through a pandemic, is Camus' The Plague, which, you know, really deals with existential thinking about you know, plague as literal, but also as a metaphor. And I think that's important to think about the ways in which we think about plagues in our lives, but gives us some hope in the end for humanity. And Jose Saramongo's Blindness, which is another great text, again, another pandemic. Sorry, Camus is an epidemic. We don't know that it leaves the Iran, but Saramongo's is a pandemic, and again allows us to explore, you know, sort of how does humanity deal with great suffering, right? And when we see this extreme reaction to this pandemic, you see the breakdown of society. We see the breakdown of healthcare, we see the breakdown of politics, we see the breakdown of economics, we see the breakdown of religion. And the book suggests how do humans rebuild from that. Not to say we're at that level, thank goodness, but it really is eye-opening to think about how fragile a lot of our systems are, how heavily we rely on them, and, you know, what do we value as a society and as individuals. So those are three that I would say are really good right now.
Thank you so much. Well, we have had so many great questions. Our hour is up. There are a lot of great questions we didn't get to, but I've invited the panelists to try and type individual responses if they would like to answer your questions that we didn't have time to do orally. There were several questions about the university opening in the fall and what are the precautions that we're taking to protect students. Right now, the university is creating a plan for how we're going to address the fall semester, and we will keep everyone posted as those plans develop. But nothing will be done without, first and foremost, keeping everyone's health in mind. It's been an engaging hour, and I thank everyone who has attended and for everyone who submitted your excellent questions for the panelists. I also want to extend a special thank you to the panelists for sharing their time and their expertise during this really busy season and time of the semester. And with that, we conclude this forum. And I wish everyone a good evening. Stay well, stay strong, and stay at home. Thank you.